is the adipose tissue. A good example for benign tumor is the lipoma. This is your slide. And if you are interested in the lipomas, there's some diversity in the histology. So angiolipoma is a subtype of the lymphoma, which is usually painful with a lot of blood vessels at the periphery of the tumor, just under the capsule, sometimes within fibroid, fibrin thrombi can be seen. Myolipoma is an interesting entity. You can have intramuscular lipoma. I don't see this, which is lipoma with risk of recidives because it occurs in between the striated muscles. So excision sometimes is not always possible, and they are very large till the patient have some complaints for that. So this for the lipoma. For the intermediate group, you have written atypical lipomatous tumor, well-differentiated liposarcoma. This is the real intermediate group. Most of these tumors are located more superficially in the soft tissues, so they are early diagnosed. And the malignant are the liposarcoma classification, liposarcoma not otherwise specified, pleomorphic one, myxoid, dedifferentiated liposarcoma. Well, I think that you should know the subtypes of the liposarcoma. We have seen yesterday the myxoid type, and the liposarcoma, which is not otherwise specified. Okay. So we finish with this group. Are there some questions for the lipomatous soft tissue tumors? If there are none, we can continue with fibroblastic and myofibroblastic tumors. Those that are absolutely benign are really very, very long list. So for the soft tissues, because you have addressed the classification for soft tissues, not including the internal organs, a typical fibroma that you have mentioned is the fibroma of the tendon sheet. I can't, yes, and you should have in mind the fibroma of the ovary, which is a subtype. It is included in the classification of the ovarian tumors that are of stromal origin. And what is interesting and important to remember is that sometimes they can produce, for unknown reason, pleural effusions, and sometimes including ascites, and it is very alarming. If you have a mass in the ovary, most of the clinicians will think of carcinoma, and it is important, of course, it's not carcinoma. Carcinoma is malignant epithelial tumor. This is benign, so we do not expect to have spreading and metastasis of this tumor. So this is an important syndrome that should take in mind. And in this group are also the Nuchal type of fibroma, but I think fibroma is okay. For the intermediate group that is locally aggressive are the desmoid tumors and desmoid type fibromatosis. I think that this is enough for as an entity for the intermediate group that will be locally aggressive, but will not metastasize. And for the group of the fibrous connective tissue region, the fibrosarcoma is okay. So in these fibroblastic tumors, probably there are about 50. I haven't counted them, but I think so. You cannot remember them. In the fibrohistiocytic tumors, you have the benign fibrous histiocytoma. And for the intermediate group, you have the plexiform fibrohistiocytic tumor. I think that dermatofibrosarcoma protuberans can be in this group. And the third, the malignant group are the malignant fibrous histiocytoma. Nowadays, they are called undifferentiated sarcoma, and it is absolutely true. So we finish with this group. For the smooth muscle tumors, you have written the benign is the leiomyoma, and the malignant is leiomyosarcoma. But there is atypical leiomyoma in the uterus that can be alarming. It can be bizarre. There are some, it's not white and black for the smooth muscle tumors in the uterus. We'll discuss this next year. So if you address your knowledge for the smooth muscle tumors, you'll find the atypical and those with unknown malignant potential. For the skeletal muscle rhabdomyoma, as an example of the benign tumor, which is usually inborn problem within the heart, is important, and the rhabdomyosarcoma is an example of the malignant tumor. For the vascular tumors, very good classification. You can use your knowledge for the cavernous capillary type of hemangioma, the AVE malformations and AOV hemangiomas is more specialized for pathologies and entities. So I don't think that you should concentrate on this when you study the classification. For the intermediate locally aggressive tumors, I will mention hemangioendothelioma without specializing the type of hemangioendothelioma, and for the malignant counterpart are the angiosarcoma. It is interesting for the Kaposi sarcoma because when Kaposi described this, it was in old patients, more than 90 years old age, and they lived in the Mediterranean region. And the Kaposi sarcoma usually occurred on the extremities of subcutaneous dark violet nodules, and the histology was the same. And the situation changed when we discovered the human immunodeficiency virus in the 80s of the previous century, in the 20th century. And it became obvious that in co-infection between HIV and herpes virus 8, this Kaposi sarcoma can occur, and it occurs not only in the subcutaneous tissue, but it can occur in all organs, including the lung, for example. In Bulgaria, we have the case with Kaposi sarcoma in the stomach. It was published. So you can have the Kaposi sarcoma's primary affecting lymph nodes, and etc. So the Kaposi sarcoma in HIV patients, it's more aggressive. I'm not sure, but I think it can metastasize, not only locally aggressive. For the group of the nerve sheath tumors, we'll discuss, according to our understanding, this group, it can be seen within the soft tissue. So this group will belong to the soft tissue tumors, but it's not of mesenchymal origin. So I will skip this because this is a topic for today. And it is absolutely true that it belongs to the soft tissue tumors, but the origin is from the nervous system. That's why it do not belong to the mesenchymal tumors. Is it clear?
Yes.
Okay. Going further, you have written the chondroic tumors and chondroma, ecchondroma and chondroma are typical examples. You had this chondroma on the hand as a histological slide. You have the intermediate group, and you have with the chondroblastoma, and you have the chondrosarcoma as a malignant counterpart. For the osteogenic tumors, you have the osteoma and osteoidostoma in the benign group, osteoblastoma in the intermediate, and osteosarcoma in the malignant part. I can skip the osteoclastic giant cell tumors. And I will focus on the tumors of uncertain differentiation. They're usually not encountered in your education, but they are important tumors that should be mentioned, and we'll discuss them next year, like myxoma, for example. It can occur either intramuscular, and this is the most common tumor that occurs in the heart, as you'll see next year. Atypical fibroxanthoma is an interesting example for the intermediate group, and for the malignant group of tumors, there is a long list that Ruha have mentioned, but for example, I'll mention clear cell sarcoma. It's interesting tumor. It is melanoma, which do not occur in the soft tissues. You have the epithelioid sarcoma, and very important is the synovial sarcoma, with not otherwise specified, which is very, very common malignancy with unknown origin yet, but anyway, it has nothing to do with the synovia, just the tumor cells have biphase differentiation. One part looks like epithelial cells, they are called epithelioid, the other will look like sarcomas, so like mesenchymal origin, so this synovial sarcoma is in this group. I was really very happy when I saw yesterday your work, because the best way of education, it's I know it's difficult when we have these online courses because it's difficult to train you. But thank you for your efforts, and I think it was really very useful for you, so you can correct. Now you have a good classification for this tumor, so you know, and you have a very good base for the next year when you study the tumors in all organs and tissue, to know to put the part for those with mesenchymal origin. Are there some questions?
No, thank you, Professor.
You're welcome. Of course, I'll check the mail from time to time. So if you have further questions on the topics concerning the slides and everything, of course, we can still use it. So now we continue with the tumors of the nervous system. And then I'll show you the slides for the melanoma. Of course, your slides, most of the slides are from melanoma in the skin, and there is one slide for metastasis from malignant melanoma. Okay, so going for the tumors of the nervous system, I want to focus that the diagnosis sometimes is really very difficult from clinical point of view. Can you tell me some interesting facts that are very specific for the tumors of the nervous system, beside their origin, for the clinic, for the behavior? What are the symptoms when you suspect that there is a tumor in the nervous system? It's good to start with these basic things.
Unspecified headaches and migraines, sudden loss of weight, severe disabling pain, or particularly pain at night, and recurrent episodes of blackouts or the syncope.
So we should resume. There are no specific symptoms, and there can be a headache, which is because of the increased pressure in the brain, and there can be vomiting, Some of the patients will have history for many hospitalizations for problems with the vomiting. And you should think for tumor of a nervous system if you have such a patient with not specific symptoms. And these are usually young people. So you should be alarmed and think of these tumors. Of course, it will be more easy if the tumor causes some signs like loss of function somewhere, or there is hyperreactivity in some region and you have seizures, for example. Okay? Or sometimes these tumors, especially those that are highly malignant, like glioblastoma multiforme, they can have large areas of hemorrhages and necrosis. But I will focus on the hemorrhages because these people are usually around 40, 50. So what you'll see on the CT because of some symptoms from the nervous system can be a very large hemorrhage, and it will be the apoplectic form of the tumor. So it's important to see behind the hemorrhage that there is a tumor tissue there. Okay, so from clinical point of view, suspecting a tumor of the nervous system, it can be a challenge. You should think of this tumor so to make the initial clinical testing, and the most important is to make CT or MRI, because from the symptoms you can properly locate where is the tumor. You'll have a cycle in neurology next year. So you'll be able to properly locate where is the problem in the nervous system. But what causes this problem is difficult to find. And that's why in neurology, you see they use a lot of image analysis, not only CT with contrast and vessel to be seen like angiography, but also MRI is a good approach for the diagnosis. So this is one of the things that is important for the tumors of the nervous system. Another interesting fact is the distribution of the tumors of the nervous system according to the age. There is no other organ that you have localization of the tumor depending on the age. For example, if you have a child, where will be located the tumor more likely? The most common tumor of the nervous system for the children group is medulloblastoma. It occurs in the cerebellum, and it is below the tentorium cerebri. And the adult people, they have their tumors above it. It's interesting fact, this distribution. And of course, it's not absolute, but most of the patients, if we can say so. And the third thing, which is really very, very important, is the grading of the tumor. What is the grading? No tumors of the nervous system are called benign. They can look benign, but if they're located on a place of the brain that compressing important centers, they can kill the patient. We prefer not to call them benign. And they are called, those that look benign are first grade malignancy. And from the tumors that we have for today to demonstrate, we'll have the meningioma and nevrinoma, which are, from morphology point of view, there is no atopia, no aggressiveness. They are well circumscribed or capsulated. They growing, they compress the surrounding structures. So location is the most important thing for the prognosis of the patient. And can you do you have the possibility to remove the whole tumor? if you have a tumor in the fourth ventricle, for example, you cannot remove the tumor. No matter whether it's benign or malignant, it will kill the patient. So on morphology, these tumors are called first-grade malignancy. Second-grade malignancy example is astrocytoma. This is the tumor that we'll start to discuss after a few minutes. This is what you see on your screen. And also you have the third-grade malignancy, anaplastic forms that have some of the features for malignancy, like pleomorphism, but not all criteria. There is such an anaplastic, for example, meningioma, and astrocytomas can be anaplastic. And the fourth-grade malignancy are the most aggressive forms. You have demonstration for glioblastoma multiforme in the adult population. But in the children, fourth-grade malignancy is for the medulloblastoma. Okay, so on grossly, most of the tumors will be white, a little bit gray in color if there are no hemorrhages and no necrosis. If you have hemorrhages in the tumor in the brain, you should be very, very careful, as you'll see later. Okay, so going on the slide for the astrocytoma, this is February type of astrocytoma. In fact, the tumor tissue looks like a culture of astrocytes. And, sorry. The February backward is well seen. To see the cells, they look just like normal astrocytes. There is some slight polymorphism between the cell, but anyway, it looks quite the same. And looking at the periphery, if you can see it, I don't know whether we have a normal brain tissue here or it's just a tumor tissue. It has a little bit infiltrative pattern. So one of the problem is to properly locate the tumor so that the whole tumor is removed. In this particular slide, there are some alarming features, but we'll discuss them on glioblastoma multiforme. This is the histology for the astrocytoma. I think it's easy slide because it is just like a culture of normal astrocytes in the brain, so it's not a problem. Be careful with these small areas that look like empty spaces. These are the microcysts. Not to think of fatty tissue, for example, because on the exam, when you are in stress, you have a practical, for example, or you have a colloquium, you think these are fatty cells. No, they are not. You have just one nucleus for the fatty cells, if they are normal. This is a microcyst, which is a specific histology finding in the astrocytoma, so it's not a problem. Just carefully read what you see. Okay, can we go further?
Yes, Professor.
Okay. If we have to stain the astrocytes, they are positive for gliofibrillary acid protein, and this is the same antibody that we use for the target treatment for nowadays for the patients with glioblastoma. Okay, because both of them and the glioblastoma can have the same origin. Now, look at the slide. This is glioblastoma. Do you have any doubt that it's malignant tumor?
Doctor, can you repeat, please?
Yes. What do you think, looking at this area, what do you think? Is it benign or malignant?
Malignant, because we have cell atypia, and also is it like this brightish color, the necrosis?
Yes. So you are alarmed because of the pleomorphism of the cells, and you have a necrosis. And in some areas, you have also hemorrhages, like on the right part of the screen. Okay, so you suspect a malignant tumor. What is difficult for the exam is to recognize that this malignant tumor is really a brain tumor. This is the problem for the students, and how to recognize that this is glioblastoma multiforme. Do you see how serpentine-like is geographic type is the necrotic area? Do you see it? And look that just next to it's very sharply outlined the verbal tissue and the necrotic area. And look how well are preserved the nuclei of the cells. They stay like fence, for example, palisading from the French word for fence around the necrotic area. This geographic type of necrosis, this palisading of the tumor cells around the necrotic area. And there is also one very important thing. Look at the vessels of the tumor. Here, for example, I think I put them in the center. We can see 1, 2, 3, 4, 5, 6 capillaries that are very close to each other, and there are some areas like this. Because we don't have a pointer, I put the areas of interest in the center. This globe in the center with proliferation of vessels, it has reminds of the glomerular structure. Do you have this impression? And this is very specific for the glioblastoma multiforme. So recognizing that this is a malignant tumor, you have a very large area of differential diagnosis. You can suspect sarcoma. This is what you should have in mind, because if you don't have normal brain tissue around, you have no idea where this tumor is taken from. That's why you have a problem on the exam. So the glomerular structures with this proliferation of the vessels, the necrotic areas with the palisading of the nuclei, and the severe pleomorphism of the cells. You can see such large areas that are highly hypercellular, and this is because you have a lot of cells proliferating. Even in these areas, you can see that there is also proliferation of the vessels here with formation of secondary lumens. Do you see this globular structure here in the center? And the polymorphism, some of the cells are multinucleated, some are giant cells like this. I'll put it in the center. Sorry for the movement. It will be better if I could use a pointer. And I'll put you a center to see. Here another glomerular structure from the center to the right part, but looking backward, look the arrangement of the nuclei with palisading just one to each other with new formation, early stage of necrosis on the left part from this glomerular-like structure. Okay, these are the diagnostic criteria. So you have the your approach is you diagnose that this malignant tumor, but you don't know the origin. This can be one of the ways. And you look for the necrosis, which are sharply outlined or serpentine-like, the palisading of the nuclei, and the vascular proliferation, and you'll have the right diagnosis of glioblastoma multiforme. The glioblastoma multiforme usually affects people around 40, 50 years old age, as I already mentioned. What is interesting, it can start from the one hemisphere and cross through corpus callosum and infiltrate in the other hemisphere. So on this sagittal section, when we section the brain, for example, during autopsy, it will be like a butterfly type of infiltration, usually with large areas of necrosis. Because the necrosis in the brain is very commonly liquefactive, it will look jelly-like, yellow in color, and of course you can have more solid gray areas at the periphery. And do not forget the large areas of hemorrhages that can occur within this tumor because of the proliferation of these small vessels, but they can easily rupture some of them. Okay, do you have some questions for this slide? Or we can go further. The third slide I'm going to demonstrate is nevrinoma. Oh, what's wrong? Probably, do you hear me?
Yes.
Okay.
Yes.
I made something wrong on the computer probably, so the screen disappeared. Nevrinoma is a good example of tumor of origin from the Schwann cells. These are the peripheral nerve cells. It can occur in the soft tissues. We usually call this schwannoma. If you remember, I said that this will be left for the tumor nervous system origin when we discuss soft tissue and mesenchymal tumors. What is interesting, look at the center. Do you see these eosinophilic lines and another row of nuclei with palisading in the center? You should remember these structures here on high magnification. Do you see how well they are organized? One row without nuclei, these are the projections of the cells, one row of nuclei. And these are the verrucized bodies. When you have these verrucized bodies, according to Anthony, these are Anthony A fields. They are very, very specific for the tumors that originate from the peripheral nerves, including nevrinoma. Beside these areas, we have other areas that makes the diagnosis difficult, and these are the areas of cystic degeneration, like here you have vessel proliferation. I'll go on the low magnification. They are not well organized, they are soft. And this is an example of cystic degeneration, like here. And what is interesting is that it can different cross-section. It will not look the same if it's large enough. Within the skull, this nevrinoma usually is located in the pontocerebral angle. It is the 8th cranial nerve. So the first symptoms will be with the coordinates in the vestibules, or it can be with decreased hearing, some deafness of the patient. And these tumors can grow very, very long time till they produce symptoms. So sometimes we have really very large tumors. And if you remember that when you have a compression somewhere, if you remove the reason for compression, you have an active hyperemia. And if you have the brain organ and you have the compression, if it is, for example, 6 centimeters, when you remove the tumor, you have active hyperemia, hemorrhage, or herniation of the brain can occur. So sometimes these tumors, when they are large enough, they are removed in 2 different operations, so to have success for this for the patient. Otherwise, no matter that the tumor is benign, it's large enough to cause symptoms, and of course, in very large tumors, probably sometimes you will not be so successful in the treatment. So here is the best way for demonstration of the nevrinoma. In the center, you have Verkai's body, Anthony A field, and on the left part and on the right part you have the Anthony B with cyst formation. Do you have questions for the nevrinoma and the Schwann cells? Is it clear? What about if I have some doubt, for example, if I have just this fascicular pattern and it is not located in the 8th cranial nerve, I'll have problem, I'll think of some other tumors probably. What type of immunohistochemistry you recommend? Which is the antibody that will give positive reaction for the Schwann cells using immunohistochemistry.
S100?
Yes, that's it. S100 protein is very good and it will work. So it is commonly used because these tumors, schwannomas, can occur not only within the brain, I said in the soft tissues, but it can occur in the gastrointestinal tract, for example. And these areas can imitate leiomyoma, something that you are already aware of. So the differential diagnosis can be really with very largely. So sometimes we need immunohistochemistry. What does it mean, phantom pains? After amputation, have heard about that?
Yes.
Okay, what's that? People are discussing.
Sorry, Professor. What did you say?
I'm asking whether do you know what is phantom pains after amputation?
Yeah, phantom pain is, after amputation, the pain due to the inflammation and of the nerve fiber ending. That is very severe usually and throbbing pain.
And what is the pathology for these symptoms?
The
Usually
neuromas
they
are
have
found on the
pain
nerve
from the
ending.
finger or the toe, but it is already not in the body. What is the reason for that?
Due to the neuroma or due to the...
Yes, that's what I want to make a differential diagnosis. There will be proliferation of the Schwann cells and the nerves, of course, but it's not tumor proliferation. So it is another case, okay? Because in this nevrinoma and schwannoma, sometimes with proliferation in the soft tissues fibrocytes, we call it neurofibroma. Are you aware from the genetics of F and NF 1, neurofibromatosis 1 and 2. For the neurofibromatosis 2, you can have these bilateral intracranial nevrinomas like the slide that you look now. And for the neurofibromatosis 1, usually you have the subcutaneous proliferation of peripheral cells, Schwann cells with fibrocytes, and they form large nodules that are seen protruding from the skin. Have you seen a patient with neurofibromatosis?
Nope.
No. Well, it's a good point to make you think of this disease. Try to find an image of patient with neurofibromatosis. Most of these neurofibromas can be in the head and neck region. So these patients start to look very ugly, really. They're with high grade risk to have other tumors, including sarcomas. At the beginning, the first symptoms are not the neurofibromas. The first symptoms are the discolorations of the skin known as café au lait spots. It will be good to have an idea for the neurofibromatosis 1 and 2. It's the proper time. Just look for the outlook of a patient, how it looks like a patient with neurofibromatosis 1. Okay? You promise me? Because there are no such spots on the skin for neurofibromatosis 2, but you have bilateral nevrinomas on the vestibulocochlear nerve. So this is the makes suspicious for neurofibromatosis 2. Okay? Can we go further?
Yes.
Yes,
Okay, the last slide from tumors of the nervous system that will demonstrate is meningioma. It originates from the cells of the leptomeninges. Normally, there are spindle-shaped cells, and there is interesting way. So in some areas, it can look like fibroma. It's not a problem. This is the fibromatous type of meningioma. Does it remind you of fibroma or leiomyoma? There is no polymorphism of the cells. It looks just like any spindle-shaped tumor without severe polymorphism. What can help you in this fibromatous type of meningioma? Do you see these violet spots somewhere? Here they are. One in the center. Do you see? I'll focus on another. One at 12 o'clock. And 2 or 3 in the lower right part of the screen. Do you see these violet things?
Yes.
What is that? Which mineral was violet in color? We discuss this every day. It's calcium.
Calcium.
Yes. These are the psammoma bodies. If you see psammoma bodies on this background, for sure it is meningioma. I'll show you a psammoma type of meningioma where most of the tumor is really calcium. But now I want to concentrate, even if there are no psammoma bodies, you can diagnose that this is meningioma, because beside the tendency of these fascicles that are formed, look at these two ball-like structures in the center. Do you see them? They form whorls. And sometimes in the center of these whorls, you have the calcium. Here there is a small area with a whorl Well, it looks like you have crossed the skin phonion. Do you have this impression? The medical term for description is not onion, but it is whorls, okay? But just to have an idea what I'm trying to show you. Another whorl center here, okay? They're more globe-like, but the cells are orientated in this specific manner. Of course, we can have different histological types for the meningioma. You can have syncytial type with more sheet-like without any organization pattern of growing. You can have transitional type or fibroblastic type or psammoma type. I'll show the psammoma type later on, but because we've discussed this meningioma should be first-grade malignancy because there is no polymorphism. We can count the mitosis. We should count mitosis if there are more diversity in the form and in the nuclei of the cells. But if there is obvious polymorphism, then we should suspect that this is atypical, or more proper term is anaplastic meningioma. And depending on the location, the symptoms can be quite different. If the meningioma is on the convexity of the brain, and it's small enough, like this, for example, it's about 1 centimeter, we expect to have this tumor as incidental finding during autopsy, or if you perform some CT for other reason. Do you see how many psammoma bodies you have? These violet things are the calcium. They are whorl structures. Just a minute to focus. Do you see how beautiful they are? This is the psammoma type of meningioma. So you can find just few meningeal cells between this calcium deposition. So if this is a small tumor on the convexity of the brain, and it stopped growing at 1 centimeter, producing no symptoms, no seizures, it can be incidental finding. But the same tumor, imagine what will happen if it is at the base of the brain. It can kill the patient. First of all, it will be difficult to remove it. You can kill the patient even during the operation. You have the risk after the removal for herniation of the brain. So the concept for using the term first-grade malignancy that is histologically benign is a good example to be demonstrated with the meningioma. Did you had a clear idea already for this meningioma and for the concept of the tumors of the nervous system? If you have some questions or if you have problems with differentiating. So for the astrocytoma, you have the fibrillary background with the astrocytes, no polymorphism, no necrosis. For the glioblastoma, you have these well-outlined necrotic areas with proliferation of the vessels, like glomerular structures. And for the meningioma, you have the whorls with psammoma bodies. For the nevrinoma, you have these verrucai bodies with palisading of the nuclei. Okay. Questions? And the last slide that we have to demonstrate is malignant melanoma. Malignant melanoma is one of the imitators in the body. And it can do a lot of problems. Which is this organ?
Lung.
Lung. What we see in this part of the lung tissue, there is some pulmonary edema. Not so good quality slide, but anyway, you have the pulmonary edema well seen here. And reviewing the slide, it's better to use low magnification. We have this brown area, do you see it? And this brown color is because of the synthesis of melanin by the tumor cells. It is malignant melanoma metastasis in the lung. So the melanoma can produce metastasis everywhere. It can produce metastasis in the lung, in the liver, in the gastrointestinal tract, in the brain, in the leptomeninges. In fact, all organs can be affected. And if we diagnose a patient with malignant melanoma because of metastasis, either in the lung, for example, or you can have metastasis in a lymph node, it's sometimes very difficult to find the primary site. Which is the first primary site that we'll think of? Where it usually starts.
Skin.
Skin, of course. Yes. Well, malignant melanoma is the most common cause for enucleation of the eye for old patients, because for young it was retinoblastoma, if you remember from yesterday. For old patients, this is melanoma of the eye, usually arising from the ciliary body or from the retina, but usually it do not produce metastasis. But the skin malignant melanoma is another story. You can see, can you recognize the skin as an organ? There is squamous epithelium with keratinization. There are a lot of blood vessels here in the subcutaneous tissue, in the derma. And here we have the beginning of this tumor lesion, which is grossly asymmetrical. And here you can see that there is different types of infiltration towards the epidermis. This is the vertical fraction, and towards the shoulders of the lesion to the periphery. This is melanoma malignum. Okay, for some of the slides that have a lot of pigment, it's really very difficult to see the details. But this is not this case. I think that we can see. What is interesting for melanoma, because some of the melanomas will not produce melanin, they are called achromatic melanomas. But what is typical, some of them will have elongated cells that will look like sarcoma. So will form nests, epithelioid type, and they will more encircle the ovoid structure with good visible cytoplasm. But the truth is that even forming nests, you have the impressions that the tumor cells do not have good contacts between them. They are discohesive, is the medical term. And beside the pigment, I will center these epithelioid-like cells with the vesicular nuclei in the center. Do you see how large are the nucleoli? Not uncommonly red in color. So looking even without the pigment, we can suspect, looking at these polymorphous cells with slightly eosinophilic cytoplasm with the very large nucleoles, we can suspect melanoma. It's easy now because we have the melanin production. But if there was no melanin, what type of staining you recommend me to prove that these are melanocytes from immunohistochemistry? S100, the tumor cells are positive. HMB45, Melan A, SOX10. We use a lot of large list of antibodies because they are very tricky, these melanoma cells. So sometimes they will not positive the reaction. I think that SOX10 is the best nowadays, but things change. So from historical point of view, S100, it's very sensitive, not specific, but very sensitive for the melanoma. So beside these nests that we have in the papillary derma that we have discussed up to now, I put the slide here to see how these melanoma cells infiltrate towards the whole depth of the epidermis. Do you see it? And even pigment can be found in the keratin. Do you see this on the left part? It's really very specific for the melanoma. And going down to the dermis, we can see where is the level of infiltration. So we can say, according to the Clark classification, what is the depth of invasion, or according to Breslow, we'll measure it in millimeters, so properly to stage the patient. Do you see how many lymphocytes are at the front of invasion? This is an important thing to remember for the melanoma because it almost always produces an immune reaction. And this is of importance prognostic value. It is important that sometimes you can have regressive changes with the melanoma. It can disappear, but it is not because the immune system killed the melanoma cells. It started to attack them, and some of them survived, and most of these patients will have area of depigmentation where was the malignant melanoma primary site. So we can say that there is full regression of the lesion. It is bad prognostic factor. So it is important. And of course, you can see that there is already invasion within the blood vessels. There is a lymphovascular invasion, even in this slide. And there can be perineural invasion with satellite nodules in transit metastasis is the term that we use for this malignant melanoma. So we can discuss a lot for the malignant melanoma. Here there is a nest of melanoma cells in the base of a hair follicle, and everything is surrounded by this stromal reaction. And because we know nowadays that the melanoma cells, they educate the immune system not to kill them. And this is one new approach for the treatment with PDL inhibitors that the melanoma cells use the normal tolerance receptors and to educate at least one of the ways. So immune therapy is important for the treatment of melanoma malignum. We started more than 30 years ago with BCG vaccination, the same that increase cellular immunity like for tuberculosis. We've gone through the interferon treatment, but nowadays for the metastatic stage 4 of the disease, we have this treatment with immunotherapy. Okay, these are the new insights from the morphology point of view through the theory. And it's interesting, we do it without testing, still having good results for the melanoma malignum. What are the gross symptoms that alarm that a pigmented lesion on the skin is suspicious for melanoma malignum? If you let me know, say,
Asymmetry.
Yes. It's easy to remember them, A, B, C, D, E, by the first letter. So A stands for asymmetry, B for the borders, C for the color, because at least in some areas you have a darker pigmentation and in some areas you have no pigmentation. So changing the color is very important, alarming for melanoma malignum. The diameter is important because even if there was a pre-existing lesion, it can start to grow very fast. So this is another alarming feature. And the evolution. Most of the patients with dysplastic nevi that are diagnosed on biopsy, I recommend them, if they have too many, to make pictures of the part of the body, usually with a centimeter to see the largest lesion. And after 6 months, for example, if they do another picture, they can see which are the nevi to be surgically removed because they are growing faster and faster. You know how some patients have very white skin and they are at more high risk to have this UV-induced malignant melanoma, because the UV radiation from the sun is important risk factor for the melanoma malignum to occur. Okay. Is it possible to have melanoma arising not in the skin somewhere else? It cannot. Sorry? Beside the skin and the eye, the melanoma malignum can occur as a primary site everywhere in the body, in fact. And the first lymph nodes, the first metastases that melanoma malignum usually produces are from the skin. They're in the regional lymph nodes. That's why it's recommended a sentinel lymph node biopsy to be performed for the patients with malignant melanoma, not to miss the proper time for therapy for these patients because it's really very, very aggressive. But nowadays, with the new approach for the treatment, we can control the disease if it is at early diagnosis, early stage for the melanoma itself. So it is important to have this prophylaxis for the patients at risk and to early diagnosis and to properly to stage them. And you know that there is also worldwide, even in Bulgaria, we have the genetic testing for some BRAF mutations that have target treatment for that. The same mutation as you can see in other tumors. So it is really of importance. Okay. So this is from me. If you have questions for the slides from today, I'm here to answer. Do you have questions for the slides that we had before?
No.
Hmm?
No.
No, everything's clear. Okay. So I think we finished this course with the slides. I wish you good luck for the session and a very nice summer. And we'll see you next year. I hope that we'll see in the real life in your clinical pathology education. And of course, we can review and discuss all histological slides that you had problems. It's not a problem. So have a happy summer.
Thank you, Professor, and you too.
Thanks.
Professor, what
Yes.
will happen with the preliminary exam? Will it exist or it will be cancelled?
I don't know. We don't have any information for the preliminary practical yet. We don't know how will be the practical for the students that finish the cycles in the fourth course. So as soon as we have some information, if there is a preliminary exam, we'll send you an email because we know most of your emails. So you'll be informed. But I think that there will be no chance for a preliminary exam for you. Up to now, this is what I know.
Thank you.
Thank you.
You're welcome.
Thank you. Dovidene.
Thank
Ciao,
you.
ciao.
Bye.
Really don't know.